Hey, everybody, it's Kevin and Donna. We're so excited to be here with you. We are talking about something that for me, Donna, it's funny. Every place that I go, headaches will follow, not headaches like people or folks you're working with, headaches when it comes to patients coming in and just not being able to do anything with them. And then the issues
Mhm.
you also encounter is that often happens and lots of things have been done with them, but nothing gets
Yeah.
taken off been done with them. So we will jump
Right.
right back to the episode to let you guys know more and hear about Donna's awesome case study right after this. Donna, I've missed your face. It's so good to see you, and I know you're taking some vacation time. So you spending
Mhm.
some vacation time with me means so much. So thank you
Yeah.
so much. And before we jump into it, like what's been going on? Any good stuff that we need to jump on right off the bat?
Wow. So I'm really excited about the RPH Ally soiree that we're having. So very excited about that and excited to maybe have some students join us too, putting that out as co-curricular activity for our students. So super excited for that and just wanting to engage students with, of course, with deprescribing, but really with all these wonderful things that we talk about in pharmacy and seeing pharmacy come together. So I'm super excited for that and for them and to see just all sorts of different pharmacy ideas coming together. So excited to be a part of that.
It's
And just, there's just been a lot going on with classes and things like that. Lots going on at the school. So great stuff happening. And newly promoted to full professor. So pretty excited about that too. So that's what's been going on.
exciting, Donna. Huge congratulations. Yeah, I
Yeah.
think that was so well deserved knowing you
Yeah.
and all the ways you contribute to our profession is fantastic. Thanks so
Yeah.
much for highlighting that because Kevin often
Yeah.
forgets to highlight the things that we're doing and we're working our buns off to get done.
Yeah.
But yeah,
Yeah.
the story is going to be so much fun, Donna. I mean,
Yes,
just I've
absolutely.
just finalized like the number of speakers that we're looking at, and we've got
Mhm.
goodness over 20 some speakers that are
Wow,
experts throughout the nation in
fabulous.
everything. I mean, it
Yeah,
just is an
that's great.
incredible smorgasbord of
Yeah,
talent. And so
yeah,
I'm very blessed, just very blessed to have so many wonderful people that care so much about advancing our profession and educating
mhm,
folks around us to say, here's what's next, or here's what could be next. And so that'll be
absolutely,
so much fun. When it
absolutely.
when it comes to our topic today,
Yeah,
Donna,
so Kevin, just one other really fun thing, that I just wanna highlight too, is I'm starting to record my book audio version, so that is super exciting for me too, so, hopefully by the end of the year, that will be coming out.
oh, so fun, med strong. And are you doing it like are you checking the decibel on yours? Or are you trying to do it like deep, low, Barry Manilow, Donna Bartlett style of recording?
I don't know, whatever the computer decides to do. I'm getting some really great lessons from this wonderful group called Audio Journal in Central Massachusetts in Worcester, and I'm able to use their studios, and it's just great. It's
Oh,
a
I'm
nice
so
win-win all around.
Oh, that's absolutely fantastic. What a really good segue. I think audiobooks,
Mm,
that's gonna be my new thing when
yeah.
I start reading.
Ah,
So headaches.
yeah.
What gave you headaches, Donna, with this case?
So,
I know you're
well,
excited about it.
yeah. So it is a little bit of a play on words, the deprescribing headaches, but it really is. A woman did come in. She was being newly treated for headaches, and ended up in the hospital because of partially because of the treatment that she had started on a few months prior. So I just kind of wanted to talk about this particular case and thinking about how important it is to probably understand the type of headaches and to be thinking, there's so many treatments for headaches depending upon what it is. We know that there's a lot of side effects to headache treatment, but also the really neat thing is that depending upon the type of headache, we might be able to dual up, if you will, on a medication and use one medication for two different purposes. So, and one being
Oh,
headache itself. So, really optimizing medicines like we love to talk about. So, I think it's really important that we don't just treat the new thing that's happening for somebody, that we actually take a look at the person, all the meds that they're on, and being proactive. Are there going to be interactions potentially? What are some of the downfalls of starting this particular medication or not? So Kevin, I did send you some slides last minute, and did you happen to get those in your email by chance? So I put the case together.
You're giving the intro. I was looking all over for the email that I should have received. I have not gotten it yet, but
Oh, okay.
let me pull up something real quick, Donna, that I wanted
Yeah.
to show kind of the audience, to give kind of an idea when it comes to headaches, and at least where
Okay.
my mind goes pretty immediately. And that
Mm-hmm.
is to massive treatment guidelines that give us, here are all the preventative treatments, here's all the screenings, here's all the types of headaches, here's all the etiologies of headache, here's all the resources that you need to be able to look through. I mean, so highly complex. And then when we start looking at the patients, like, it's an interesting matching game then from there,
Right.
that I think is once again very complicated. Of where do we tie these dots together? We have a hypertensive patient, or we have a patient that has glaucoma, or whatever the case may be, and trying to choose the
Right.
right treatment to balance everything
Right.
across, I think becomes really difficult. And I'll share my screen right now just to show you the one I'm looking at. It's out
Absolutely.
of Australia, Donna. Let's see right
And
here.
Australia does some great things, I tell you. I love their studies. I love their guidelines. It's
Yeah.
so
So
amazing.
not to, I mean, don't worry, audience, if you can't see this. Wasn't intended to go into a deep dive or anything, but just looking at
Mhm.
the key points, the massive like list of red flags
Yeah,
to look, other features with
right.
family histories and symptom severity, to be able to see, like, are we diagnosing this appropriately even in the first place? And then that
Mhm.
only leads to the examination stage and understanding like what presentations of these types of headaches could be, let alone some of
Right.
the things that could be actually secondary headaches, overall. So when you brought it up,
Exactly.
Donna, I was like, oh man, I remember. uh, you got to tell me this when I'm getting your slide deck to come across.
Yeah,
What's the
which that's
strangest
okay.
or the most interesting thing you have seen try to be utilized for headache?
I think kind of what we're gonna be talking about today.
Is it
So,
really
yeah, so
super?
divalproex and tizanidine as a combination for the medications. So, I am going to send you a PDF instead of the actual slides. If you'll give me just a second, everybody. But in the meantime, I can be talking about this whole issue of what happened with our patient.
Yeah.
So, um, so anyways, we have a 78, I'm sorry, a 70-year-old female, and she has COPD, and she has increased shortness of breath. She doesn't have like any chest pains or anything like that, no fever, no chills. So she actually comes into the hospital because of shortness of breath and potentially a COPD exacerbation. However, when we really start looking at her medicines, you can't help but see the number of medications that are an issue for this patient.
Okay.
So, um, so I'm going to go through some of her past medical history, some of her issues, anxiety she has. She has arthritis. She has kidney, chronic kidney disease, COPD, type 2 diabetes, um, hypertension. She's had a history of TIA, um, headaches, hypothyroidism, and dyslipidemia. So kind of a lot of things that we see together anyways, right? And then we have a whole host of medications that she's on. So some of the things that I want to bring to your attention are the apixaban that she takes. So it's a anticoagulant. So looking at that, probably because of her past TIA experience and AFib that she's had. So those are some of the issues. For her inhalers, she's on both Pro Air and Symbicort. So those are kind of not necessarily appropriate for her COPD. For some of her other types of medicine, she's taking carvedilol for heart rate, and and she's off of any other blood pressure medication because her blood pressure is very low, typically. She's on oxycodone, have no idea why. We can't really see a reason for that unless she's really taking it for arthritis, but it'd be kind of extreme if that were the case. So things that like just don't seem to really be matching up very well for her. She takes sertraline for her anxiety, and about a month ago, she had to have it increased. So instead of 50 milligrams once a day, it was increased to 1.5. Uh, um, so 75 milligrams daily. And then for tizanidine, she was using that, and divalproex, just started that a few months ago for these headaches. And she's calling them migraines. However, when she's talking to us, and I love that you put up, all those different types of, how headaches present, etc. She tells us that she gets a very severe pain for maybe at most 15 minutes, but it's like debilitating for about 15 minutes most days, or just too often. Like even if it's every day, every other day, might subside for a little bit and then she'll get them again in a grouping. So that type of headache typically is not considered migraine necessarily, especially when it's that short of a period of time. And it tends to be more of a cluster type of headache. So when we're looking at the medicine that she was given, the divalproex and tizanidine, those can be used together for migraines. Not your typical use, but that's what was provided for her. And that started a few months ago. Okay. So when we start to really look at her medicines and start tearing apart some of these things, first of all, why is she in? She's in for COPD. So most likely. So she is taking albuterol and the budesonide and formoterol long-acting inhaler, but her eosinophils are not greater than 300. So she's already being her medications are not lining up for her. So there's like a mistreatment going on in regards to selection of the medications. So really, according to the GOLD guidelines, she should be more on a LABA-LAMA combination. So something more like if you just want to use one inhaler, would be a Noro Ellipta, which would be an option for her. So that's something to be thinking about, is maybe even switching that. Then we go on, and she comes into the hospital and she has hyponatremia. And we talked about this another time. We talked
Yeah.
about hyponatremia. So when we're looking at this hyponatremia, you want to think about what could be causing it, right? And so this new drug, divalproex, that she's taking, and she increased sertraline. Both of those things can cause hyponatremia. Hyponatremia can also lead to confusion and falls and other things that could be potentially harmful for the patient. So anyways, sertraline, as we know, was recently increased because of anxiety, and divalproex was started a few months ago. Well, think about this. Divalproex can also increase the risk of anxiety. So here we have, we know too that people with COPD, um, or any type of breathing problem too, have an increased risk of anxiety. So between some breathing issues, adding on the divalproex, we've just increased the potential for anxiety that much more for her. So so let's keep moving on. There's more to this. So then we're looking at the AFib, right? So she has AFib and she's continuing to take apixaban, and she takes carvedilol. So carvedilol is not really an AFib drug necessarily. It does help heart rate, but we often choose more of solid beta blockers only or calcium channel blockers. So we tend to see more the metoprolol or maybe a verapamil or diltiazem being used for AFib for rate purposes. So when we're looking at this, and this is when I start when I started talking about, hey, you could actually use one medicine, take care of a couple of things, right? And we try to be creative with that when we're looking at pharmaceuticals. So verapamil could be used for the rate that she needs help with, but it also helps for headaches, and it has an off-label use for cluster headaches. So, really nice piece of treatment that could be used throughout for many purposes and won't have some of these issues that we're seeing for her. So, thinking about switching to verapamil. And but here's a couple of things to also think about. So when we're thinking about AFib and the apixaban that she's taking, we also have to be careful of drug-drug interactions. So verapamil can actually cause an increase of apixaban. So we might need to watch for bruising, bleeding, signs and symptoms such as that, and reduce verapamil accordingly. Um, Divalproex, though, it reduces the effectiveness of apixaban. So we're not even getting a good enough effect of this anticoagulant that she's taking. So another issue. So when we're thinking about, the headaches of this person and what was picked to treat her headaches, really incredible. Like all the issues with this particular selection.
Donna, I'm
Yeah.
curious if you can tell me this. Why do you think those two drugs were chosen? I mean, outside of the provider thinking I've done this 100 times before and this is the regimen I've gone with. What's the
Yeah.
rationale when you saw this? You thought maybe they were
I
thinking this?
yeah, no, I honestly couldn't figure it out. And that's why I was looking it up. And I actually had to look up that this combination is used for headache and migraine prophylaxis, actually. So I didn't know that these two were typically used in trying to figure out why are you taking each of these medications, as we do that when we're trying to figure out purpose of the meds and necessity appropriateness of the medications. So it was actually the sleuthing that we as pharmacists do in trying to figure this out and saying why would this be started, but knowing, like, from our history, it said, oh, this was started a few months ago for headaches. Like, we could see that in the charts, but I was just, I didn't quite know which type of headache was being treated for with that combination. So, and they
Fascinating.
were started together. And
I'm
tizanidine for an older adult is, again, we're looking at a anticholinergic burden of 3 and an increased risk of falls and tachycardia and other issues. And when we have AFib going on, it's going to be an issue. So just not a good choice. I can't imagine why. It was chosen. I know a lot of the other meds that are used for migraine are more um, for for more treatment, if you will, especially the triptans. But what I'm thinking is where she was having these so repetitively, maybe they thought that wasn't an appropriate use and they wanted to do more prophylaxis
right.
versus treatment of. So that would be my only reasoning, but really not a good choice necessarily
Because
for
in
this
my mind,
particular
I
patient.
was looking at that and hearing what you're breaking down for the patient, and I'm thinking, if I'm a clinician and I'm seeing this patient has low blood pressures,
Mm-hmm.
immediately one of the things that you could go to is I can't use a BP med. I can't
Right.
use one of those, so I switch over to other medication profiles, and I see, well, divalproex is not a blood pressure medication. Think, okay, I guess this is the one I'm going to use. But
Yeah.
the combination with the tizanidine was an interesting one to me. If there was like other muscle pain or history, and hearing the
Yeah.
oxycodone, I was thinking, well, maybe they were thinking there would be a combination utilization effect there.
Mhm.
The reason
Mm.
I ask, and I'm sure everybody knows,
Yeah.
including you, is usually if someone chose something, there's a reason why in
Yeah.
their mind they broke it down. And so when we're doing the retraining that's part of our jobs to do, how do we allow that algorithm in their minds or inside of the healthcare system to go,
Mhm.
this was not a good choice, and here's the reasons why inside of there.
Yeah.
So anyway, thanks for humoring me for kind of looking.
No, of course, of course. And I think too, like, I'm not certain if, um, like, diagnosis was actually understood other than, one-sided pain on the head. Yes, that's a migraine, but
Right.
for 15 minutes, that's not typical. So I found, I think in understanding that, like, not knowing how that conversation went. Oh yeah, I've been getting horrible headaches on the side of my head. Maybe time frame wasn't asked, but we asked, like, so how long does it last for?
Yep.
So I don't know. I can't quite figure it out. Um, and I did not see any history of any triptans being used at all. So I thought it was an interesting first start, if you will.
Totally. Yeah, and I think, Jim, you're hitting on the head with what Don and I are both thinking. There could be that exact same process going on. There could be multiple specialists, a general practitioner, looking at the full EMR. I know that Donna did have all those records, at her access and disposal when she was looking at it,
Mhm.
but that doesn't mean the practitioner load isn't significant. Do you know, Donna, were there a
Right.
number of specialists involved with this particular patient?
Yeah. What? I'm not quite certain. I think that there was some specialists, but I believe that this was just started, like general practitioner kind of idea, from what I remember, because I don't remember seeing a neurology.
Great.
So yeah.
That's super helpful.
Um, so moving on, if like we want to make certain that so like I just want to back up on the verapamil for a moment, in that it is a treatment for cluster headaches. It's also prophylaxis for migraines. So depending on how we're looking at this, but divalproex and tizanidine, they are indicated for migraines only. That is their indication when it's combined, like as it is and for this particular patient. So I do think that sertraline is an important product for this patient, and not having necessarily had hyponatremia before, that increase might have caused that hyponatremia, but also the divalproex, and also the divalproex causing this increased anxiety, most likely.
Yeah.
So I think that's a great reason to take that away. The opioids, there wasn't a clear indication. We could not find a reason why opioids were being used, and they'd been on for some time. But also, if you think about it, Kevin, when we're looking at tizanidine added on with oxycodone, there's more chance for respiratory depression. And here we have somebody with COPD on top of it. So again, something that we really don't want to see combined together, and especially in those that already have a potential issue with respiratory depression anyway.
So true.
Um, so by the end, thinking about what we really want to be stopping, especially at first, is to stop the divalproex and the tizanidine. Switch around carvedilol to verapamil might be an option, but of course, carvedilol would have to be slowly tapered, and then verapamil added on. Having to watch for blood pressure and heart rate, of course. So all that monitoring needs to happen as we go through this process, right? And it is a process. It takes time to do these things. So that's but sometimes when you're in the hospital, you have that ability to make those changes and to be monitored and see what's going on and react accordingly, if necessary. So that is a good option to try that while being in the hospital. So trying to get that the sodium back up, but not causing it to be lowered again, because as soon as somebody leaves the hospital and there's probably medications that cause the hyponatremia, if they're not adjusted, they
Yep.
will most likely be readmitted. So that is an issue that we want to make certain we're trying to avoid. We also want to think about the efficacy and effectiveness of the apixaban and what we're choosing. So that's a real important
Mm.
component for this particular patient. So here we have some of these high alert drugs, if you will, and what we want to be careful of. And so we have to be careful of what we're adding on to those for sure.
Yeah, I love that, Donna, that you re-highlight that piece with the apixaban, because I feel like oftentimes we don't recognize how we're either enzymatically or from an efficacious just standpoint, potentially adding on a regimen that could pull away someone's ability to be able to prevent stroke or future heart attack. And I think
Yeah.
oftentimes we throwing on things like, when we were using warfarin, I mean, I'm gonna make myself sound really old now, but when we were using warfarin, we're always concerned about those things, right? We're always
Mhm.
concerned
Yeah,
how's it going to interact. Now that we're
absolutely.
moving toward these more advanced agents that don't require the same level of monitoring, it's easier for us to be able to
Mhm.
add on an agent that could have a deleterious effect on how impactful those are to prevention.
Yeah.
And so I love that you highlight that. When it comes to the other elements of migraine. I know for like the
Mhm.
study we're looking at, we're specifically looking at the regimen, potentially looking at just pulling off two agents that have been problematic, probably the oxycodone 2, seeing what's happening with the overall pain
Mhm.
management in general, and the anxiety is going to be part of the
Mhm.
equation. But when it
Mhm.
comes to headache etiology and dietary and or lifestyle factors, Donna, any
Mhm.
other
Mhm.
elements there or nuggets that you pulled away in this case?
Yeah, well, not necessarily in this case, necessarily, but yeah, just share a funny little something that um, on our walk from the School of Pharmacy to where we park, there used to be a restaurant and it was wine, cheese, and chocolate. And when the signs went up, I went, well, there's a migraine waiting to happen. Because that's all I could think of was trigger, trigger, trigger. So we have to be careful of certain products that we're taking in, certain dietary items. So we definitely want to be super careful of alcohol, caffeine, and anything that can potentially um, cause increased blood pressure, if you will, too, which is a side effect of headaches are a side effect of high blood pressure. So things that could do that, we have to be very careful of. The other thing we need to be careful of is timing of medicines too. So when we're looking at these medications that this patient is taking, we want to make certain that they're using it appropriately. How often are you supposed to be taking it, and are you timing it well?
Mhm.
I have another really interesting case where this person was asking me about blood pressure medicines, and she was taking them so much on odd times, and her timing of meds was so varied, versus every 12 hours. Some were just every 6 hours instead, and then if you extend it around, so you have a 6 hour window, and then the other side you're what, 18 hours. So having some issues there and wondering like why she wasn't doing well. So sometimes it's the timing. It was more involved than just that, but we want to make certain that people are actually taking their meds appropriately.
That's a
Um,
great point on pharmacokinetics of just saying, like, when you take some drugs, especially if they are a preventative agent, if you're not keeping
Mhm.
those blood levels up where they need to be, sometimes you can have breakthrough incidents. So, so tell me this, I guess, last question
Yeah.
from Kevin's side down. It was
Yeah.
you threw on the prevention elements, for her in play with the verapamil. When it comes to something to be able to help it get through or weather the storm with either the cluster, which you're suspecting there, or the
Yeah.
diagnosis of a migraine, anything you added on board on that side?
Yeah. So, so this is kind of interesting. This was a little bit puzzling. And I think in this particular case, Prevention is most important because she doesn't necessarily get an aura or anything of that sort. It's this
Mhm.
intense pain for about 15 minutes. If you take something, it tends to be, you're going to have a little bit of a delay, unless it's some type of injection or, maybe some the nasal formulation. But so we didn't really talk about that because before you know it, it's gone. And so really think prevention is super important here. And I think that's why these particular agents were used was for prevention, but it was prevention of migraines versus prevention of cluster.
Got it. No, that's super interesting. Well, thank you so much, Donna, for running us
Yeah.
through that case. Sorry I did not get the PDF.
I know, I'm sorry I didn't make its way, but I do hope it was still interesting for folks and, that they were able to follow along just as well.
I'll take a picture of that PDF and I'll attach it to the show notes. And
Oh,
so folks
perfect.
can see that and be able to follow along on that side and give us their insights.
Yeah.
Jim, Jolene, and all the other folks that were watching, thank you guys so
Yeah,
much for
thank
tuning in
you.
and throwing some questions and comments. We always love that. If you have any other questions or comments, head on over to Donna's channel and RPH Ally at rphally.com, the Deprescribing channel, and let's jump into it because I think that's the whole point of our soiree, Donna. Is I think the
Yeah,
future of medicine is pretty bright, and it's Deprescribing is a big part of that.
yeah.
All
Thank you
right.
so much, Kevin. Always great to chat.
Everybody have a great night. Talk to you
Thank
then.
you, everyone.